Hello, my name is Melissa Zambrano and I'm going to talk about a phase 3 trial of serolipase alpha and lysosomal acid lipase deficiency. Definition: lysosomal acid lipase deficiency is an autosomal recessive lysosomal storage disease that is fundamentally based on the systematic accumulation of cholesterol esters and triglycerides in the cellular lysosome. This disease is characterized by multi-organ involvement, which includes the liver, spleen, cardiovascular systems, and to some extent, the gastrointestinal system.
Yeah, so recently there's been a lot of discussion about a new condition. It's actually an old condition that we've kind of resurfaced. It's called LAL deficiency, or lysosomal acid lipase deficiency. So what is it? It's a condition in which the liver can't process cholesterol esters correctly. So either because of the food that we ingest that has cholesterol, or as a consequence of the body recycling cholesterol, it comes back to the liver as cholesterol esters. Those esters have to be broken down into free cholesterol for the body to use it once again. And therein lies the problem. They don't have a digestive enzyme within those lysosomes in order to do so. As a consequence, two things happen. One is the cholesterol levels will go up. Again, in most of our experiences, that looks like it might be familial hypercholesterolemia, so our inclination is to treat these with standard drug therapy, including statins. The problem is that cholesterol ester is trapped inside lysosomes, and those lysosomes reside in the liver. And as a consequence of all this cholesterol ester, that cholesterol ester is going to cause damage to the liver, and ultimately it's going to cause scarring or cirrhosis. So these people get into serious trouble with liver failure. Interesting enough, the therapy that we offer to lower cholesterol, statins, may actually make that condition worse, because what they do is upregulate the LDL receptor, cause more cholesterol esters to be incorporated into the liver, but they can't go anywhere. They don't have an enzyme to digest it. So there's new and promising therapies on the horizon. We hope that that'll be FDA approved sometime in the near future and it'll be safe and effective. But it basically is replacing the enzyme that's deficient. And as a consequence of that, hopefully the liver function studies will normalize. Short-term studies up to a year, we've seen dramatic improvements in liver function studies as well as the cholesterol level. So stay tuned. I think lysosomal acid lipase deficiency may be something on everybody's horizon here in the near future.
Application in medicine. Lysosomal acid lipase is an enzyme that processes cholesterol and triglycerides ester in the hepatocyte of individuals. In lysosomal acid lipase deficiency, when LDL is taken by the LDL receptor and transported to the lysosome is swollen and enlarged with cholesterol esters and triglycerides. Therefore, cholesterol and free fatty acids are not released. In addition, hepatocytes also upregulate the synthesis and packaging of cholesterol, which releases even more cholesterol as a result. Ultimately, LDL is deposited in hepatocytes, macrophages, and the endothelial wall, which can lead to clinical manifestation of disease of the heart and liver, as well as inflammation of the spleen and intestinal manifestation.
My name is Mark Goldberg. I'm Executive Vice President for Medical and Regulatory Strategy at Synergiva Biopharma. We're studying lysosomal acid lipase deficiency, which is an autosomal recessive disease due to mutations in both alleles of the gene that encodes lysosomal acid lipase. This enzyme is critical in cholesterol metabolism. When an LDL particle binds to the LDL receptor and gets taken up by the cell, the cholesterol esters and the triglycerides within the particle are hydrolyzed within the lysosome into free cholesterol and free fatty acids. And when this enzyme is deficient or absent, there's a dramatic increase in the amount of lipids that accumulate in the lysosomes of the cells throughout the body, but particular in cells of monocyte macrophage lineage and hepatocytes. This leads to progressive accumulation of fat and steatosis in the liver, usually a microvesicular steatosis, so that progresses to fibrosis and cirrhosis, and leads often to liver failure even in childhood. There's also a dyslipidemia marked by a high LDL and a low HDL and a variably elevated triglycerides that leads to accelerated atherosclerosis. First of all, extensive preclinical data and a very relevant animal model that showed by giving a recombinant human enzyme to replace the deficient lysosomal acid lipase, we could get the enzyme to bind to mannose and mannose 6-phosphate receptors on cells, get internalized, traffic to the lysosome, and replace the missing enzyme. We showed that we could reverse the fatty accumulations in the liver in this animal model. We could improve growth in the animals and improve survival. We've now moved into a phase 1/2 clinical trial that is described in this poster. In that study, we studied 8 adults over 90 weeks being treated with the enzyme, and we showed that with every other week treatment, we could see a dramatic decrease in the previously elevated transaminases. They started elevated, they came down into the normal range, and they remained in the normal range during this 90-week period. Similarly, with replacing the missing enzyme, we see a mobilization of the accumulated lipids. So once the triglycerides and the cholesterol esters are hydrolyzed, we initially see the mobilization as evidenced by a transient rise in cholesterol and triglycerides, but with continued treatment, these decrease to below baseline levels, and by 90 weeks we see about a 50% reduction in LDL cholesterol compared to the original baseline, a similar decrease in triglycerides, and a modest rise in an HDL as well. The study is now ongoing, and we have a phase 3 trial in children and adults that's now fully enrolled and is maturing at this time. We hope to have data from that trial in the latter part of this year.
Pros and cons. 7-lipase-alpha is an human recombinant lysosomal acid lipase. It should be avoided in patients with hypersensitivity to it or its products, since it occurs in the eat whites of genetically modified hens. In addition, in clinical trials, approximately 3% of patients experience anaphylaxis, chest discomfort, dyspepsia, and rash. Other adverse effects relate to the drug include diarrhea, vomiting, fever, rhinitis, anemia, couch, nasopharyngitis, and urticaria, which occur in at least 30% of patients with progressive disease in the first 6 months of life. Wallman. In addition, headache, fever, oropharyngeal pain, nasopharyngitis, asthenia, constipation, and nausea occurred in more than 8% of pediatric and adult patients.
My name is Irene DePiazza, and I am an assistant professor of pathology at the University of Utah. I am also medical director at ERUP Laboratories and share the responsibility for the biochemical genetics lab. Today, I would like to discuss a rare and possibly under-recognized cause of liver dysfunction and dyslipidemia. Lysosomal acid lipase deficiency is an autosomal recessive disorder characterized by the accumulation of cholesterol esters and triglycerides in the late endocytic system. The disruption of the cholesterol homeostasis in those patients leads to an upregulation of cholesterol synthesis and uptake. This vicious cycle increases circulating low-density lipoproteins, leading to liver disease and dyslipidemia, which progresses to premature atherosclerosis and cardiovascular disease. Minimal residual enzyme activity is associated with the most severe form of this disease. Wolman disease onset within months of age with severe gastrointestinal symptoms and rapidly evolves to hepatic and adrenal failure. Unfortunately, Wolman disease patients usually die in infancy. A higher residual activity for the enzyme is seen in milder form of the disease. Patients with cholesterol ester storage disease present later and have usually a better prognosis. However, although the severe form of this disease is easily recognizable, identifying the milder phenotypes is challenging due to the similarity with other vascular, liver, and metabolic diseases. Liver disease is present in most of those patients and progresses to fibrosis, micronodular cirrhosis, and ultimately to liver failure. The liver involvement might be what brings those patients to the clinician attention, and often the liver biopsy is requested before considering the rare diagnosis and before ordering diagnostic testing specific for this condition. The microvesicular steatosis present in those patients is not specific, however, is not commonly seen in other types of liver disease and should trigger follow-up biochemical testing. Lysosomal acid lipase deficiency should be considered as possibility in patients with hepatomegaly or liver functional impairment, always after an abnormal liver biopsy that shows microvesicular steatosis, or in patients with dyslipidemia that cannot be explained by other risk factors, like obesity. To exclude lysosomal acid lipase deficiency, we suggest starting with the biochemical testing. Enzyme activity can be measured in several sample types. We will start offering testing at ARUP this summer in whole blood. Samples can be sent already collected on filter paper and dried, or in collection tubes. The yellow top collection tubes is the preferred specimen, but we accept several other types. Once the enzymatic test shows deficiency, the diagnosis can be confirmed by molecular testing. It is important to identify those patients because the recombinant human enzyme is now available for enzyme replacement therapy. Clinical trials are ongoing, but the results published and presented to national meetings are really promising. Enzyme replacement therapy is well tolerated and produces sustained results. So it's really essential to identify those patients and start therapy early before the permanent damage occurs. For more information about biochemical testing for lysosomal acid lipase deficiency, you can check out our website or you can email me.
Issues applied in Ecuador. The enzymes and prevalence in Ecuador are related to the cardiovascular events that are a consequence of them. The available epidemiological data show that there is a direct relationship between plasma cholesterol levels and the incidence of coronary heart disease. This relationship is maintained in linear form with normal cholesterol values, but when it exceeds 200 milligrams DL of the cholesterolemia, it becomes exponential. Prevalence is estimated early or early onset 1 for 3,500 persons.
Lysosomal acid lipase deficiency, or LALD, is a progressive and rare genetic disorder that leads to fat accumulation in the liver. It's caused by mutations or changes in the gene for the lysosomal acid lipase enzyme. It also results in abnormalities in the fats or lipids in the blood. LAL-D affects both males and females, and it affects individuals of all ages. LAL-D is a disorder that affects many different organ systems in the body. Infants with LAL-D have very serious and rapidly progressive symptoms, often beginning in the first few months of life. And these include failure to thrive, poor weight gain, enlargement of the abdomen, which is due to enlargement of the liver and spleen, and often gastrointestinal symptoms like diarrhea. In the absence of treatment, the condition progresses quite rapidly, and often children succumb to the disorder before their first birthday. LAL-D affects both children and adults by leading to progressive accumulation of fat in the liver with resulting inflammation of the liver, which ultimately leads to scarring, fibrosis, cirrhosis. The treatment for lysosomal acid lipase deficiency is what we refer to as enzyme replacement therapy. Patients are missing an enzyme called lysosomal acid lipase, and the treatment gives it back to them. So it corrects the underlying basic defect in the disorder. The benefits of the treatment appear to be very significant. So importantly, in the liver, we see a reduction in the fat accumulation in the liver as measured by imaging studies. We also see improvements in the blood tests that we do. I anticipate starting all of my patients on treatment just as quickly as possible.
Conclusion. It is a disease of lysosomal deposit of so-called rare disease, produced by the decrease of absence of activity of the acid lipase in the lysosome, with alteration in lipid metabolism. Treatment with lipase off results in reduced spastic and lipid alterations in children and adults with VLID. The superposition of the main clinical manifestation with other diseases of higher prevalence dyslipidemia forces us to establish the differential diagnostics, especially in those patients without response and treatment.